divided into mild, moderate to severe sight-threatening orbitopathy. The clinical activity score, if 3 of these 7 signs or symptoms are present, then it indicates that the disease is in the active stage and might need medical therapy. In the initial stages, the symptoms include grittiness, staring, photophobia, with more severe inflammation, pain with eye movements and retroorbital pain, as well as orbital fullness. Signs include lid retraction, proptosis, diplopia, and in more severe cases, exposure keratopathy and vision loss due to optic neuropathy. The clinical course, as described by Rundle, runs 2 distinct areas. From 18 to 24 months, the disease is active or inflammatory stage, and then it goes on to a more stable inactive stage. So these are important to recognize because your therapy or treatment depends on these stages. Imaging is definitely very helpful in diagnosis as well as surgical planning. So you do both CT scans and MRI. So medical management in early cases, you make sure that the thyroid is under control, you stop smoking, and you provide lubrication. The steroids are the mainstay of treatment in the acute stages. If they are not working, then immunosuppressants and radiotherapies can be used, and more recently, biological therapies. So steroids are most effective because they inhibit the inflammatory cascade in a very early stage, and they block all the cytokines and stimulation of the orbital fibroblast. The other immunosuppressants and biologicals target various receptors in the different parts of the body, parts of the cells. Surgical management is performed mainly in the inactive phase, and you follow this sequence by decompression, strabismus surgery, and lid surgery. Very occasionally, you might need to do an emergency decompression in the acute stages if there is optic nerve compression. So orbital decompression can be approached either medially, inferiorly, or transconjunctivally, laterally, or do a balanced decompression both laterally as well as medially. So just show you a little video of medial wall decompression through endoscope. This is the middle turbinate. You pack the middle meatus with the adrenaline-soaked gauze, and you see the uncinate process, the hiatus semilunaris, and the bulla ethmoidalis. So you incise the uncinate process and start removing the mucosa and enlarging the hiatus semilunaris. So once you've done that, then you enlarge the infundibulum by either help of a balloon catheter. You remove the lamina pepratia after removing the mucosa over it, and that exposes the periorbita on the medial aspect. Then you incise the periorbita. You have to be very careful because the medial rectus is just next to the periorbita here, and you prolapse the orbital fat and the orbital contents into the nasal cavity. So once you've done the decompression, then you do the strabismus correction. Always remember that you do recessions in thyroid orbitopathy. Never do a resection of a muscle in them. And also for inferior recessions, you need to dissect the connections between the lower lid retractors and the inferior rectus. After that, you can do an upper lid levator mular muscle recession for lid retraction. For a lower lid, you can use spacer grafts. Can I have the slides again, please? And last step is the blepharoplasty. So recent advances include a multidisciplinary care in management of these patients involving endocrinologist and an immunologist. As I've already told you, teprotumumab has been introduced for as a adjunct to steroids, and a number of other biologicals are in the pipeline. Endoscopic decompression I've already shown you, and the conformal radiotherapy with a gamma knife is also helpful in these patients in acute stages. So the key takeaways include that thyroid orbitopathy is an autoimmune condition. It has active and inactive phases which define the management of this condition. Balanced decompression is preferred in them. Long-term follow-up is essential, and you can't discharge these patients. Thyroid eye disease causes significant visual, ocular, and cosmetic morbidity, and multidisciplinary approach with endocrinologists, immunologists, and an orbital surgeon provides the best possible care. A timely and systematic approach with both medical and surgical management can effectively address the functional and cosmetic concerns. Thank you very much.
Okay, thank you, Dr. Amer. That was fantastic. Now, my friend is Gangadhar Sundar from Singapore. He will speak about the orbital fractures, highlight the orbital fractures in 7 minutes.